Muller from the University of Queensland. I'd like to thank the Immunisation Coalition giving me the opportunity to speak to you today about some of the work we've done over the last few years developing a COVID-19 patch. So as I'm sure everyone is well aware, as we've just lived through the COVID-19 pandemic, the SARS-CoV-2 virus emerged in late 2019 in Wuhan. It's the causative agent that causes the COVID-19 disease. And so far, the virus itself has caused around 759 million confirmed cases and almost 7 million deaths. Over the course of the pandemic, we saw incredibly rapid development of vaccines. We've seen 180 vaccines are still working their way through clinical development, with more than 199 vaccines in preclinical development. What was really amazing was we saw vaccines go being approved in under a year for novel vaccine platforms that have never been used in people before. And while these vaccines have been exceptionally good at mitigating some of the risks associated with particularly severe COVID and hospitalization, all of these vaccines are limited by the cold chain and require highly trained medical staff to deliver the vaccine. So what we're working on at the University of Queensland in collaboration with Vaxis is what we call a high-density microarray patch, or simply a patch. And what this is a cutaneous vaccine delivery platform. So we have a high-density microarray, which is roughly a centimeter square in size, on which we have thousands of microprojections in the order of 250 micrometers in length. On these projections, we're able to coat the vaccine onto the projections, and these projections go into the skin, deposit the vaccine, and then come out. When we are developing our coating formulations for this patch, we design them to be relatively fast dissolving, so very short wear times are required for the patch in the order of 10 seconds to 2 minutes. And we apply this patch using an applicator. It's a very simple to use applicator, and this opens the door potentially in the future for self-administration. This is just a video showing you how simple it is to apply a patch. Basically, with one finger, you can push down on the applicator, and inside that applicator actually contains the patch. And it's designed so that it takes away any of the underlying structures of the skin and just creates a uniform surface, so the patch will work on a wide range of skin types and different underlying tissue structure as well. One of the really great things that we have from using the applicator is that we find that the dynamic application of the patch allows us to reproducibly focus the layers of the skin that are rich in antigen-presenting cells, particularly the dermal layer. And as a function of the dynamic application, we get this very controlled cell death around each of the projections. And what we see is that this, this mixture of live cells, dead cells, and vaccines, you actually set up a really potent inflammatory response. And this leads to greatly enhanced immune responses. And when you look at in comparison to ID, you can see ID goes much deeper in the skin, into the tissue, and doesn't cause the same level of cell death. So if with the patch, we're able to produce even logs better immune response than you'd get with a simple ID injection. So one of the things, given that the patch has all these great attributes, it doesn't mean much if you can't manufacture, and it has been designed to be able to be manufactured at scale. The applicator itself is actually the primary packaging. So there's a sterile seal, and the patch, which is coated with the vaccine, goes into this assembly, and it's able to be coated inside this assembly and then sealed and simply applied. And Vaxis has spent a lot of time developing pilot lines with the goal of producing from a pilot line around 25 million units of vaccine per year. So given we're working on this high-density microarray patch, at the beginning of the pandemic, we were looking at how we could get involved. and we're looking at some of the different vaccine modalities that were around and what we thought would fit well with the patch. And what we decided upon was a pre-fusion stabilized spike protein called Hexapro, which was developed by Jason McClellan's group at the University of Austin, Texas. So what is Hexapro? Very simply, they've introduced 6 proline substitutions into the molecule to help stabilize it. And then with the addition of a bacteriophage fold-on domain at the base of the protein to maintain a folded state, a trimeric state. And because of this, this greatly improves the stability of the protein. And so this made it an excellent match for the patch. And when we actually got Hexapro into the lab, we found that it was very easy to express in XP293 cells, and we're able to get very pure products. We were able to generate trimers, and that can be seen here on the size exclusion profile. And it was also antigenically authentic, where we were able to test it against a range of antibodies that we had in the lab at the time. We also went a step further. We did electron microscopy, where we were able to visualize the spike protein under the electron microscope, and we did single particle reconstruction and developed a low resolution molecule just to confirm what we were making was, structurally authentic. So once we were able to make enough protein, then we went on to do some limited formulation screens. And what we actually identified was human serum albumin, recombinant human serum albumin was the lead excipient. And this imparted great stability profile, particularly outside of the cold chain, where we were able to demonstrate 30 days at 25 degrees C, we were able to get 100% retention of the protein in its active conformation, and 7 days at 40 degrees. And we've since done further analysis with these formulations and been able to take this out, extend this beyond 3 months as well. So this is a really great finding, and lends itself for that lower and middle income country vaccination. So once we were able to stabilize the protein, we did some coating experiments on the patch where we coated the vaccine, and we were able to see that we had excellent coating morphology. As you can see, this retention of our projection shapes. And what we did then was we delivered this to mice to work out how well our vaccine transferred off the patch into the mice. And you can see the tide marks where we're able to deliver the vaccine. So we know we were able to efficiently deliver the spike protein into the skin of mice. And based on this, we were ready to then move on to evaluating the performance of this patch in context of an immunization study. So initially, we established a BALB-C model where we vaccinated mice via the patch or intradermal vaccination, and we gave the mice 2 micrograms of protein, and we did this with and without the adjuvant QS21. Mice received 2 doses of vaccine 3 weeks apart, and we also, at the completion of the study, we collected the bloods, and we also did bronchoalveolar lavages to look at the immune responses in the lungs. And what we found, we were able to get good antibody titers after a single dose with the patch, and these were significantly greater than the responses we saw for the intradermal vaccinations. These responses boosted particularly well, and something we were really happy with was even without adjuvant, we had really very strong immune responses to the spike protein, even without an adjuvant. So just because we had high antibodies, it didn't mean they actually were functional. So next we looked at the serum neutralization. And what we found was that basically our IgG titers were reflected in our ability to neutralize the virus. And after a single dose, we were getting strong neutralizing antibody responses with the patch, and we saw no responses via traditional needle and syringe. Again, we saw the boosting of these responses that mirrored nicely. We extended this and started looking at some of the variants. The 614G virus was a variant that emerged early on in the pandemic. And we saw that we're able to maintain our ability to neutralize this virus. And then we looked at alpha and beta viruses and again saw that we were able to maintain potent neutralization against these different variants of concern from mice that were vaccinated with the Wuhan virus, or Wuhan spike. This is just another way to look at the changes in the titers that occurred when you compared the wild type virus to the different variants. And as you can see, we're not really seeing any significant loss of neutralization titers using the patch. So we also looked in the lungs, as this is a respiratory pathogen. We were interested in how did we get any immune responses in the lungs? And when we looked at the bronchoalveolar lavages, we found we were able to generate an antibody response against the spike protein. This correlated with neutralizing antibody responses as well. So we're able to neutralize antibodies in the lungs for both the 614D and 614G viruses. Given the volume, we weren't able to test this against the other variants of concern. So given we saw such strong neutralizing antibody responses, and as pandemic has progressed, we're interested in seeing how did our responses that we got from that initial vaccination study stack up against some of the more recent variants of concern. And what we found when we vaccinated with the patch, particularly when we had adjuvant, we were able to really maintain very good neutralizing titers against all of the variants of concern that we've tested, including Omicron, which was a really exciting finding. And this data was published in Vaccine last year. So given we saw we had really strong neutralizing antibody responses even after one dose, we moved on to do a challenge study where we vaccinated mice with or without adjuvant, and we gave them 1 or 2 doses via the patch. We omitted the ID groups given the patch greatly outperformed the needle and syringe in our immunogenicity study. And so here we vaccinated mice once or twice, and then we collected the bloods after the dose. We challenged the mice with a Victorian isolate of SARS-CoV-2, and we monitored mice for survival, weight loss, and we looked at the viral titers in the lungs as well. And so what we found was, again, when we looked at our neutralizing antibody responses, all of the mice vaccinated produced neutralizing antibody responses after a single dose, regardless if it was with QS21 or not. We saw those responses boost greatly with a second dose. And when we looked at the different variants, again, we saw it pretty much mirrored our initial study where we saw good neutralizing antibody responses against the different variants that we tested as well. So when we actually looked at the challenge, what we found were the naive mice, once they were infected, they rapidly lost weight, with all the mice succumbing to the virus and having to be culled on day 6 post-infection. Corresponding with that, we saw this dramatic rise in clinical score, and we found really high viral loads in the lungs and also in the brains. When we analyzed the vaccine groups, so mice that received a single dose of Hexapro on the patch without any adjuvant, we saw partial protection, where we saw half of the mice succumbing to the virus on day 6. And then we saw the corresponding clinical score. And when we looked in the lungs, interestingly, we found that there was no SARS-CoV-2 in the lungs of these mice. However, there were quite high viral loads in the brain. And we think this has to do with the model. the K18 ACE2 mice express ACE2 everywhere, and there is a nerve that runs from the nose all the way to the brain, and we think that has how the virus is moving along, because this doesn't really mirror what happens in a human. However, when we moved to a single dose with the spike plus QS21, we found we were able to completely protect mice from infection. There were no signs of weight loss. There was absolutely no clinical score. And when we looked in the lungs and in the brain again, we saw absolutely no virus. So we had complete protection from this virus with no viral breakthrough. When we looked at the 2-dose groups, again, we found we saw no weight loss. We saw no clinical signs of infection or clinical scoring. And when we looked in the brains and the lungs for both groups, with QS21 or without, we saw no viral breakthrough detected. So what we found here was that we're able to express and make Hexapro and use it as a subunit vaccine against on a patch, and it demonstrated excellent stability profile. We were able to recover the protein after extended periods outside of the cold chain at 40 degrees and 25 degrees Celsius. We induced potent virus neutralizing antibody responses after a single dose, and these boosted really well with the second dose. The immune response was faster and more potent with an ID injection. We based on our findings, you'd say QS21 or an adjuvant may not be required. What was really promising was the ability that the antibody response against SARS-CoV, against the spike protein, was able to neutralize basically every variant of concern or every variant we have actually tested it against. We're able to completely protect mice from the virus as well with a single dose with an adjuvant or 2 doses with or without. So based on these results, we actually transferred our patch and all of our assays into Vaxis for phase 1 clinical evaluation of Hexapro as a COVID-19 booster. So as part of this transition, in the lab at UQ here, we use a coding style where the vaccine goes over all of the projections and on the base. And while we have good delivery efficiencies of around 40 to 60%, this isn't really ideal in a context of a vaccination because you don't want to leave the bulk of your product on the base of the patch. So then we transition to Vaxis, where they have printing systems which directly dispense vaccine to the tip of these projections. And by having the vaccine dispensed directly to the tip, you're able to get around 80% delivery efficiency. So greatly improved transfer efficiency into skin. So given this now, Vaxis has actually just completed the dosing from the clinical trial, where we did 3 different groups of patients, where patients either received a single Hexapro map delivering 15 micrograms and 2 placebo patches, or they received 3 Hexapro patches for a total dose of 45 micrograms, or the placebo group, which just received uncoated patches. We chose to go this path initially as it was the easiest way to manufacture these patches. You can do a single manufacturing run and just get the elevated doses through multiple patches. So we are awaiting on the study outcomes, but we're quite hopeful that this should be a very good booster vaccine. So I like to end presentations talking about a white paper that was put out by Avalia Health in March 22, and that's looking at the economic and public health impact of microarray patches in administered vaccines and pandemics. And some of the findings of this paper was through dose-bearing capability, streamlined storage and distribution, and simplified administration, MAP vaccines could mitigate the public health and economic consequences of future pandemics. And they also did analysis of what would have happened if we had used patches from the beginning of the pandemic, and they saw it would reduce the pandemic by 150 days. There'd be significant fewer deaths, and it would have greatly reduced the economic impact. So with that, I'd like to acknowledge my team who did a lot of this work, in particular, Dr. Chris McMillan and Dr. Jovan Chu. And thank you. I'm happy to take any questions. And again, I'd like to thank the organizers of the Immunisation Coalition for giving me this opportunity to present. Thank you.
So, David, are you there?
Yep, I'm here.
I think this is going to be our first hitch because we're having trouble. Got him on the line?
Yep, I'm here.
So, all right. So, the first question I had was, is it likely that we can see treatment for COVID coming on as a patch? So, injection-based combination of drugs will soon be available for respiratory viruses. Will that be the same that we'll better use a patch as a single drug application?
So Scott,
go on, thanks. Sorry. Yeah, good to see you. Thank you.
Yeah, so I guess the goal with the patch is to use it as a vaccine delivery system. Ultimately, would like to be able to do this as a combination product. The idea of a respiratory patch is extremely attractive as well, but in the initial phases, we'll be focusing on just vaccine delivery. We won't be looking to use antivirals or anything in combination.
Another question we've got is that the title is a single and it's complete. So I think you wouldn't say bragging, but you're telling us that it's a complete and a single program. What's complete and what's single?
What's complete and what's single? So we saw complete protection using a single dose of the Hexapro patch. So that was that's the title. Not sure.
So you don't need a booster, like in real world, if we were using it on humans, would we be doing a 6-month booster? What do you know, or you don't have that sort of data?
We don't have that sort of data yet. So yeah, this is just a preliminary study in mice. The clinical trial has just concluded. The interim results were announced a couple of weeks ago, where we saw on average an 8-fold immune response in a booster study. So it's a significant immune response. Yeah,
it's pretty impressive. So well done. So Peter Richmond, you got a question?
Yeah, thanks. Thank you. Really nice data, and I look forward to seeing the results of the sort of, particularly the persistence of immunity in the phase 1 trial. My question is really about chasing the variants. We've just heard that all the regulators have agreed that the next COVID-19 booster vaccine will be a monovalent XBB1. How quickly can you change and produce a batch of vaccines to address that sort of chasing the variant, which is clearly one of the advantages of the mRNA vaccines?
Yeah, so chasing the variants is variant whack-a-mole is one of the challenges. Really, so in terms of getting it on a patch and having it work, we've found alpha works, beta works, delta works. Any spike we put on the patch so far works very well and effectively. The biggest issue when it comes to actually GMP manufacture is the time it takes to actually establish the GMP cell lines for this type of vaccine. So it takes a period of months to generate those cell banks to express your protein.
Okay, so it's still pretty exciting. So anything you'd like to just comment about absolutely fabulous work? We've been waiting for a while, and to see that protection in the mice, and to see no. So last question from the floor, and remember, anyone who's got questions, please send them in, because there is an opportunity to send the questions to the speakers and answer them offline. So if you do send a question in, give us a chance to answer it. Last question, thank you.
Thanks very much for a great talk. I'm Stephen Lambert. I'm a public health physician from Queensland Health. In thinking about future applications for a product like this, using them remotely without cold chain, can you talk us through what the applicator is made of, and in terms of waste, how it's handled, particularly infection control after the patch has been delivered? Thanks.
Okay, so I guess the way the applicators, so they're made, this sort of changes as Vaxis changes their manufacturing processes and optimize it. But at the moment, it's looking like it will be made of a aluminium shell, which will contain the spring and the coated applicator, so that the idea is that these patches will go out, and they'll be also sent with a sort of a biohazard bag that you can put your spent patches into. One of the nice things about this particular patch is because of the density, you really need an applicator to get it into the skin. So otherwise you hit a bed and nails effect. So in terms of potential misuse or actually refiring, you cannot refire the applicator. It self-disables once it's been fired off. So in terms of infection control post an application, it's unlikely that you'll actually be able to get the projections to break the skin barrier. You need the applicator to overcome the stratum corneum.
Okay, thank you. So really pleased that we could get you online. It's fantastic. Your talk was fantastic. Great to have you online. Appreciate your input. Thank you very much. I hope the weather's warmer there than the cool welcome we've had here. Thank you. Thanks, Dave.
Thank you.